Well, good morning, everyone. A special welcome to those of you joining us for QI Power Hour for the first time. This is Gary Tier at the Health Quality Council in Saskatoon. QI Power Hour is a free monthly WebEx offering hosted by the Saskatchewan Health Quality Council. It provides an opportunity for colleagues across healthcare as well as from other industries to hear from local and national improvement experts on a variety of quality improvement related topics. So just a reminder that for following today's session, a recording of the event will be posted to our Health Quality Council website. You can share out the link with colleagues who are unable to join us in person today. And we also invite you to check out other recordings from past presentations of the QI Power Hour. While you're on our Health Quality Council website, we also invite you to sign up for our distribution list. This will ensure that you receive regular invitations to all our upcoming QI Power Hour sessions. Over the last number of months, we've been delighted to see how QI Power Hour has continued to spread through our province, within our provincial healthcare system, as well as to other organizations in Saskatchewan who have an interest in quality improvement. We've also begun to see spread to other organizations within Canada and even internationally. Again, welcome everyone to QI Power Hour. Now I'm going to pass the mic over to Chelsea Schwartz, Provincial Improvement Consultant here at Health Quality Council, to cover a few of the interactive functions involved in today's webinar. Chelsea?
Thanks, Gary. So good morning, everyone. As Gary mentioned, I just want to remind folks of the different ways they can contribute to today's session. So the first function that I want to cover is the annotation function. So you can access the annotation function by clicking on the pen icon on the top left-hand side of your screen. And then I invite you to select the arrow icon and let's give it a go and practice this function by indicating where you're joining us from this morning. So clicking the pen icon followed by the arrow icon. Oh, sorry guys. I'm just realizing that we still had Ashlee as the presenter, so our slides weren't advancing. They're advancing on our end. All right. There we are. Thank you. Perfect. Thanks, guys. Excellent. So we see that we have some folks joining us from Ontario this morning, from our neighbors in Manitoba, some folks joining us from inside the province. Stacey's pointer can't actually point to where she's actually at, so as far off the map as we can get. See, Ashlee's joining us from over here in the Atlantic, so thanks, everyone. So we also invite you to join us by using the chat function today. So this is a great way to share your insights and your questions as they come up throughout the presentation. You'll find the chat function over on the right-hand side of the screen, and you can access it by clicking on the chat bubble. So I'll invite everyone to practice that function by indicating what organization they're joining us from today. So just a reminder to please select all participants when you're using the chat function so that everyone can share in the conversation. University of Windsor, Heartland Health Region, eHealth Saskatchewan. Excellent. So it looks like we're getting the hang of that one. It's always good to make sure that all of our functions are working before we actually move into our presentation. So glad to see that that's working. And finally, we also invite you to log onto your Twitter account and tweet out during the session to share your learnings. You can use the hashtag QI Power Hour and the handle HQCSask. You'll also see the handle for the Q community. So if you include all of those handles, we'll really be able to spread the great reflections and ideas coming out of today's session. So with that, I'll pass it back over to Gary to introduce our two speakers for this morning.
Thanks, Chelsea. I'm delighted to welcome this morning Stacey Lally and Ashlee Biggs from the United Kingdom's Health Foundation. They're leading some unique work to build the improvement community across the National Health Service in the UK. And here at Health Quality Council, we're looking carefully at what they're doing because we'd be interested in doing something similar here in Saskatchewan. So we're delighted to be able to learn from their experience and welcome them this morning. So Stacey Lally is Head of Delivery for CUE. This is the community that they're going to be talking about, and joined the Health Foundation in 2015. Her work focuses on both the delivery of CUE as well as the internal organizational development required for this kind of initiative. Previously, Stacey's work focused on national leadership development within the NHS and the charity sector. Our second speaker is Ashlee Biggs, and she is the Senior Communications and Stakeholder Manager for CUE. Previously, Ashlee worked in policy in a government relations role and as a public relations and marketing communications consultant for the private sector in resources and mining. So that's dear to our hearts in Saskatchewan. And as well with various healthcare quality organizations. One of the core areas of her work was with international mining companies as a community relations manager in negotiation roles, particularly working with traditional landowners and their communities. So we're excited to hear from you, Stacey and Ashlee. Over to you.
Clearly. So Stacey here. I'm going to get us started, and then I'm going to hand over to Ash to talk about our communication and engagement approaches. So big thanks to Health Quality Council for connecting with us and wanting to hear our story. Really delighted to be able to share it with you, and looking forward to some of the questions you might have. I hope you can answer them. CUE is a relatively new initiative, even though it's been going for 2 years. It's, I guess, when you're building something that is, you hope to be very long term, the first few years are really important, aren't they? So we're going to cover off where the initiative has come from and what we are, what we're trying to achieve, share some of the key areas of learning to date, a bit about our member experiences, and then the communications engagement piece, which is really important when working with a community that are so dispersed around the UK. Do use the comments box. We'll keep an eye on them as we're going through, and if there's things that we can't answer in this session, we can always follow up with some thoughts afterwards. Right, so I'll get started. I thought I'd just start by talking about the Health Foundation initially, in case there are some of you who haven't heard of it. So the Health Foundation is an independent charity. It's committed to bringing about better health and healthcare for people in the UK. We give grants out to those who are working on the front line. So we're also commissioning and carrying out research and policy analysis. So our aspiration really is to connect what works on the ground to effective policy making. And you can see there from the slide that since 2004, we have invested over £120 million in the front line of the NHS, and I think that's just such a privileged position to be in a cash-strapped system. So in terms of how we work, we share what we learn, we collaborate with other organisations, and we build people's skills and knowledge, and that has a real connection to what we do in CUE, which you'll hear more about shortly. So CUE is one of the flagship programmes of the Health Foundation. So I will move on to CUE. CUE is essentially a human infrastructure for improvement. So it is bold in scale and simple in aim. What we're trying to do is to make it easier for people to share, to learn and collaborate, because we think that's the thing that will help us all have a greater impact for the benefit of patients. And at the end of the day, that's why we all do the jobs that we do. And I think there's a challenge around these types of initiatives because people are often connected to many different networks and initiatives, and I think it can sometimes feel like a drag on people's time, and that's one of the big conversations that we tend to have. How can we actually make it easier for people to be connecting? So face-to-face is so important for building those relationships, but there are lots of other ways in which we can help people with their problem solving and taking their learning back into their organisations. So the saying "still with pride" is something that we actively encourage. and actually it's countercultural to some organisations. So that's always an interesting debate. I'll move on to talk very briefly about where Q has come from. So Q was born out of the 2013 BEREC report. So this was a report that was published in the wake of failings of care at the Mid Staffordshire Hospitals NHS Trust in England. And I've no doubt that many of you, will have seen some media on that over the years. This report basically made a case for the NHS to become an organisation devoted to continual learning and improvement, and it made a specific recommendation to establish improvement fellows. So Q was subsequently established in 2015 as a result of that report. So whilst it started off with safety, it was very interconnected with the patient safety collaboratives in England. It's now much broader, so it covers all domains of quality, and it also covers the whole of the UK, which I think is a real kind of shining star of this initiative. So we now have more formal country partnerships with colleagues in Northern Ireland, Wales and Scotland. I think England has a lot to learn from some of the initiatives in that part of the UK, particularly in Scotland. So it's great that the 4 countries can come together. And just to say, I think the Health Foundation were approached by the NHS to do this work, given some of our experience both in the field of improvement and research and policy, but also the independence of and stability of an independent organisation. So in 2015, we were given 5 years initial funding, and that's when we started to develop Q. So Q is motivated by our experience that ideas don't spread down the corridor, let alone kind of to everywhere that could benefit. And you often talk about care in hospitals, and you've got 2 wards that are performing completely differently. And after decades of improvement in the UK, thousands of people that have been trained, there's still a gap in skills, and many of the change efforts fall short of expectations. And I don't know about you, but this is pretty much how my baking attempts turn out. And I think it's a really nice indication of how improvement can work at times. Moving on to my next slide, we've learned that defining and identifying improvement activity just isn't straightforward. It's really complicated, and we can share a bit more information about that through the presentation. People often don't actually realise what they're doing is improvement, and I think that's a really interesting point when we're trying to recruit new members to the community, because actually they're just doing their jobs, don't really label it as improvement. And I think it's also because, that there's a range of different terms that we might use to describe the work involved in making things better, and I think that can be confusing for people. Many of you will know that improvement is a contested, expanded field. It encompasses work on lots of different issues, so it can be quite complex for people. So what you'll see here on this slide is those isolated pockets of improvement. They're all disconnected. They're all going off in different directions. So there really has been little opportunity for people to be sharing and connecting. And then 2 years on, I've just jumped over my 2 slides, apologies. 2 years on, we're understanding more and seeing more connections being made, as you can see on this slide here. We are, as I said, at the very early stages of building and sustaining a long-term infrastructure, and the ambition, of course, is to get to something that looks like this, where we've got lots of connections happening, lots of sharing of learning, and that's our ambition, essentially. And when you think about some of the examples in practice, so have a think and reflect about what are the challenges that you're grappling with at the moment, and how might you go about solving them, or at least getting part way to understanding how you might solve them. So you'd probably need a mix of skills and ideas. In terms of skills, you might go on a training course, or read a book. But then when it comes to specific ideas, you actually probably want to find someone who's already solved it or someone who's involved in it. You might look at a book, and then I guess if you're really lucky, somebody's already developed a toolkit on it because they've been through that experience already. So that's the opportunity that Q brings, which I think is part of the human aspect of it as well. So, and the human aspect, of course, is the membership. So we have over 2,000 members in the community, 2,152 to be exact. So our members of the community are able to seek out people working in improvement to help build those connections, share their challenges and successes, and learn from one another. And I think our hypothesis is that this will bring about a change in their practice, a culture shift almost, in how people work together outside of their usual boundaries of the organisation. So outside of the organisation, outside of the region, and then across the UK. And essentially what we're trying to do is develop a knowledge sharing culture. And there are lots of different ways in which we do that, which I'll talk about in a second. So during 2017, we decided that actually one of our focuses really needs to be scaling our membership at pace. So we recently announced our final wave of members for 2017 joining, and that has taken the membership within just under a year from our 231 founding cohort members. So they're the people that helped us design it, and you can see them there in the top right-hand corner, standing in cheesily in the shape of a Q. We couldn't resist doing it. And we're now up to 2,152 as of last week, which is no mean feat operationally, but we're really seeing the benefit of actually having a scaled membership. The other thing to say is that one of my colleagues has written a blog about some of the lessons that she learnt about how you welcome people into a community like this, and I'll make sure we share that through the chat box or afterwards on email. So I guess we have a really rare and precious opportunity here to think deeply about what will really help large-scale change and how to do this. So we started a year-long co-design process with our founding cohort, who I just mentioned. We think this is probably the largest co-design process in the history of healthcare improvement. So we generated tons of insights through that process, and we've actually written a 50-page report that goes through our learning process, so what we've learned, and we'll share that with you. It's available on our website. We'll share it either on the chat or an email afterwards. There's an exec summary. I know time's tight, but it's an interesting read about all of the nuggets of learning that we've had along the way. A big part of that, of course, is our evaluation and our connection to some of the research and evidence around what it takes to build a network. It's important to say in the co-design process, we had no rigid, preconceived idea of how best to develop a community at this scale. So although we could draw on previous Health Foundation programs and evidence reviews about the role of networks, for example, and we also were in contact with leading thinkers in the area, and we were able to kind of seek specific input where we needed it. What was interesting is our level of comfort with working with ambiguity. So for our founding cohort who'd never joined a group like this, or certainly never been tasked with designing a new initiative, a lot of our work was actually working with them to understand how they were feeling through the process. So us at the Health Foundation didn't have a blueprint for what this should look like. We weren't requiring consultation. We really wanted them in there in the thick of it, designing it with us, so we could really understand what their needs were. And it was both brilliant and challenging and difficult, and a lot of fun at the same time. So I'll move on briefly to talk about some of the offers in Q, and there is a host of information on our website if you're interested in having a look at a bit more detail. So with Q, it really is up to members how much time they want to make for, I guess, being in the community and being active in the community. But we are learning through our, I guess, member insight is that people are looking for more guidance than we're currently offering them, and that's quite a live thing at the moment. we're having some discussions about actually when people join, how do we point them in the right direction or actually seek commitments from them for what they're going to do within their first year, for example. And I think the thing that people have found challenging is that you come into a community like Kew, there are so many offers and so many different ways in which you could go, it can feel a little bit overwhelming. So that's one of the key things that we've been talking about very recently. As I mentioned earlier, time is a real big factor here. So it's a voluntary community. It's important for us to recognise that people will do different things at different points in their career. So they may want to dip in and dip out of the community, and I think that's fine. This is a long-term initiative. Wouldn't it be great to have something that's there for the whole of people's careers for when they needed it most? There is a huge amount of activity to draw on, so that can be really light touch through social media. We have a really active Twitter account, and actually we've been doing some tweet chats, which have been really successful. And actually the good thing about those is that people from outside of the community, so non-members, have been joining in that. And one of the things we talk about is actually how we take our learning outside of the community to share it with others. And then there are opportunities for deeper connections and deeper learning that we might do through our workshops or our events, for example. Some of those are, many of those are face-to-face, but we're trying to, I guess, balance that challenge around the time. So activities are generated in lots of different ways. So there are some via the Health Foundation, I guess the central Kew team in London. We have a number of partners across the UK who we give funding to deliver networking activities, etc. for members. And then there are the members themselves. So one of the great things, I think, is some of the member-generated activities. So we have a variety of specialist interest groups. They have been created by members for members, although some of them are inviting other people in, which is a great development. They're coming together, and as the numbers of Kew have been increasing, what we're seeing is some energy around a particular topic, for example, and then wanting to connect and work on something together. And our hope is that has impact in the longer term. One of the other offers that we do, slightly lighter touch, is our randomised coffee trials. And for anyone who hasn't heard of them, they're a great way of meeting a stranger, is my kind of summary. So every month, a Kew member can be matched with someone else within the community. You'll receive their email address and details, and you arrange to have a half-hour phone call. So that could be a phone call, a Skype call, WebEx, Zoom, anyway, or face-to-face for anyone who happens to be local, just to talk about their work and get to know each other. And what's been great is there are some little stories emerging from there about the connections that people are making. I should also mention rather our national event, because we have it next week. So we're very busy at the moment with the last minute planning things for our national event. We're bringing nearly 400 people together in Liverpool in the north of England for a big learning and sharing event. We've got some great speakers and sessions for them. We'll be doing a live blog, and we'll make sure that we share that with colleagues, so you can have a look at the nature of what we're trying to do through some of our events. I think people get a lot of energy out of them because it is that face-to-face contact that happens, and of course we need to balance that with some of the other areas. You'll see there on the left-hand side of the slide our member directory, and that's a way for people also to interact. You can look up members in their regions and see where they are and send them a message. The final bit in terms of how we are, what we're offering Kew members rather, is our Kew Lab. So the word lab can be used quite a lot. So what our lab is a space, a place to bring people together to work on a complex challenge for a particular period of time. So colleagues who are working in the lab are using existing knowledge to develop an in-depth understanding of the particular issue. They're developing ideas, testing solutions, and then sharing their learning. And the theme for this lab, which is our first pilot lab, is around peer support. So you'll see there on the right-hand side what would it take for effective peer support to be available to everyone who wants it to manage their long-term health and wellbeing needs. What's been great about that is that we've brought a number of people together, over 130, as you can see from the slide, and it's made up of not only people from the community, so there are other people outside who are doing this work anyway, and the lab brings that opportunity to kind of broaden that and bring people together. Again, we've got more information that we can share on that, and we'll be really interested to see how that develops. This is our first time doing it, so it's our pilot lab. So that summarises some of the things and opportunities that members have, and I guess the thing we're trying to do is understand what their experience is like. And there's a whole host of things that we'll never know is happening. It's not for us to be monitoring everyone's activity, but what we do want to talk to members about is to really understand what their experience is and how it's making changes. One of my favourite bits to talk about with Q is about the connections that people make, and that's not just through the randomised coffee trials. It's through the face-to-face events, the contact on the member directory. As part of RAND's evaluations, that's RAND Europe, who we're working with, we use a technique called social network analysis. So this was tracking how the relationships developed during our design year with our 231 founding cohort. So this technique comes from other sectors, and what they've realised is that improving the informal connections between people is an important part of innovation and improvement capacity. So we focused on this within the co-design phase of Q. One of the examples is that we had a co-design event up in Scotland, and it was a 2-day event. So there was a dinner overnight, and we had a ceilidh. So a few of the Scottish members wanted to organise a ceilidh for the evening, and it was the second event. And those informal connections, probably there was something about dancing and contact that actually really built their relationships, and actually probably, as far as we know, or as far as we're concerned, made a bit of a difference to their work. When they're back to their organisations, they connected with those people again. In terms of the social network analysis, what was really interesting was the change over that period of time. So each dot on this social network analysis representation is a person. So each connection there is a line, and the bigger the dot, the bigger its nodal centrality. So it's showing how effective people are, I guess, as the conduit for information and support. So the proportion of respondents reporting at least 10 connections increased from 13% on the left-hand side to 70% on the right-hand side. And I think that's a great way of describing the connections that were made through that process. So the average number of connections people reported at the start of the co-design process was 4.7, and then that increased to 14.9, which I think is phenomenal. And there's a lot more information about this in our Building Q report. And I think paying attention to individual connections and behaviours and how people work together, as well as what you're producing, is a really, really important part of building a community. I'm happy to answer any questions on that, and I'll move on to my final slide before I hand over to Ash, just to kind of cover off the importance of the diversity of those connections, actually. So it's a really diverse community of frontline health and social care professionals, as well as patient leaders, managers, researchers, commissioners and policymakers. And we think that this really boosts the power of Q as a source of innovation and kind of practical problem solving, because what we're doing is trying to include such a wide range of perspectives. Of course, the really tricky thing is providing or designing interventions and offers for people that meet all of those needs. So I think that's probably the biggest challenge with having a diverse community. So within that community, when they join Q, there is an application process. Again, we can share more information on this. I guess what we're looking for is people who are actually doing improvement. So we want them to have a level of experience and understanding. We want to hear some examples of what they've done. And then the most important bit that also connects to their to the behaviour bit is the kind of thoughtful commitment to queue. So we are asking people what they want to get from the community and what they want to give back. And that's an important indication about whether they're going to be an active member. And we realised, you know, again, that a time issue, that can be very difficult for people, but we're very clear that this is here for people's careers. So that covers off who's in the community, and our member directory is completely public facing, so you can have a good nose around and see the people in the community who are based in various areas of the UK and some of the things they're interested in. We are doing lots of development on the member directory as well, and have also recently developed a map so people can put themselves on the map and see where they're located. That is me then. So I hope that overview was helpful. I know there's quite a lot of information to get in. As I say, our website is full of information for you to have a look at afterwards. So I'm now going to hand over to Ashlee, who's going to talk about our communications and engagement pieces. Really, really important part of what we're trying to do within Q. So I'll sign off for now and hand you over to Ash.
Great, thanks, Stacey. Just checking my microphone's working, and it looks like it is.
All good.
Great, thank you. I thought it would be helpful just to give a little bit of context of the environment that we're working in, particularly from a communications perspective. So Q is a new initiative. We're starting something from scratch, but we're also borrowing the brand of the Health Foundation and NHS Improvement. So it's about treading a fine line between keeping everything within those brand parameters, but also sort of developing our own brand for Q as well. The audience that we are working with don't have a lot of time. We've got junior doctors who have barely enough time to be able to get home between shifts and get back to work. We have got patient leaders who have long-term health conditions who are also managing that and taking part in Q as a volunteer. It's a real complex and diverse ecosystem, and I use the phrase ecosystem really, really meaning it, I suppose. It's moving about. We've got government departments, we've got research organisations, we're working with third sector organisations, and there's frequent amounts of movement between those departments. And then the final piece of the puzzle, I suppose, is the financial constraints that we're working in within the NHS as well, and we need to be very respectful of how we spend our money. It's charitable funds, it's also government funds, and make sure that everything is appropriate as well. I thought I would cover off what our communication strategy objectives are, and the first one is around increasing the awareness and understanding of Q. It links very much to one of the first context points that I raised about building a brand within Q. So people haven't heard about Q when we first started, and it was about introducing them to something. We have a name that is quite ambiguous, arguably. So Q stands for quality. It's attracted quite a lot of attention just simply because of the name, because people are very curious. What is that? What does that mean? The second objective is about raising the profile of members and the improvement work that they are doing. And Stacey mentioned before that improvement work can be very isolating for people. Some people won't even be recognised in their organisations that they are actually doing improvement work, and through Q we hope that we can contribute to raising the profile of them as individuals, but also the work that they're doing, and that's part of helping to spread the work that they're doing and connecting and sharing with other members. Our third objective is about building and maintaining lasting and meaningful stakeholder relationships. So Q works. It's a network of networks. We sometimes describe it as an umbrella of networks, and it works because of the relationships that we build. We've had to build relationships with 18 partner organisations who helped us recruit those 2,000 members. We have built relationships with organisations who are hosting members to go on to site visits, for example. And we're also building relationships with organisations and senior leaders who are promoting Q and who are encouraging their staff to give time to invest in the community and invest in their improvement work. Now, this fourth one is about increasing the profile and contributing to Q's mandate to continuously improve and contribute to influence better capability, capacity and conditions. Now, this links to Q's overall aim, and this is a long-term objective, but through Q we believe we can be contributing to, like I mentioned before, increasing the amount of time that people have for improvement, the skills that they have and the conditions that they have, that environment that appreciates and welcomes innovation and improvement. We run bespoke communications approaches through Q. So by that I mean that we have different techniques for different sub-projects. I quite like this then because it captures our approach really nicely. In certain circumstances, we will take an influencing approach to our communications, and that particularly is when we're trying to influence senior leaders or perhaps chief executives of hospital trusts or employers of our members, and encourage them to give and protect more time for their employees and their staff to contribute to Q. Disseminating, so we will target particular members where we know that there is an activity that is relating to them. It's more effective, and we have a really good response rate. So, for example, if we know that there are members who haven't got subscriptions to particular learning resources, then we will just target those members with our communications. And broadcasting, and this has been most prominent with our recruitment strategy. We didn't know how many people would meet a criteria to join Q. We didn't know who those people were. So by broadcasting, we were reaching the aim of increasing the profile of Q. We were reaching the people who would be able to apply to join Q. And we were also reaching people who may not be ready to join Q yet, but they were building that awareness, and it's plants a seed of perhaps later on I'll be able to join, or I'll keep an eye on that. They've got some really good resources on their website. I'll really quickly cover off some of the channels that we use. So Stacey's mentioned the website. That's our primary communication channels. It's only a year old and we are building on it. We are applying a little bit of agile, doing it bit by bit, iteratively testing different components. We've recently created the capacity for members to create online group spaces and online chat functionalities. Our next phase is about implementing a significant taxonomy throughout the website, which will automatically group people who have a similar area of interest or are working in a particular professional group. Ecoms, like many organisations, we send a lot of emails, and it is something that we are watching. We don't want to overload people with emails, but at the same time, we've found that it's quite an effective way of reaching people. Twitter is also, as Stacey mentioned, very prominent in our communications. I've included LinkedIn, and I thought it was important to share our experience of LinkedIn is that it hasn't been very successful. We find that it's not very successful in the sense of people self-organising and driving the conversation themselves. It's required us to be driving those communications, and it's a theory of ours that a lot of people are on LinkedIn when they are job hunting, not necessarily when they are looking around, just trying to find information. We have a lot of events, so we host events, which is a good way of reaching people, but also this year we've invested a lot of time into going and presenting at events, whether they were small local events or whether they were national and international conferences. And we've done that in a variety of ways, whether that was small breakfast sessions or whether that was plenary theatre. To me, the ambassadors are most valuable communication channels. The people that are talking about Q and the word of mouth of something that is worth investing in, that's something that is really giving benefit and has the potential and is showing impact, is incredibly valuable. We've got connectors within the community, so they are people who are have self-identified themselves as being more actively engaged and also referred to as network weavers. But we've also got people we know are just really enjoying Q, and we make sure that we frequently connect with them and that they feel very up-to-date with what is going on within the initiative so that they can also be telling people. And our partner organisations, we've both mentioned previously that we worked with a variety of organisations to recruit members. We also work with NHS Improvement, who are co-funders, and we've also got partner organisations as well in Scotland, Northern Ireland and Wales, and we use their communication channels. My last couple of slides are around our community engagement approach. So at the moment, and for the last nearly 2 years, our community engagement approach has been very much like creating and watching a garden naturally evolve. So we have got a full-time community engagement manager, and he has been helping special interest groups to surface, collecting people together and pointing people in the right direction, but very much letting things naturally evolve. And the results of letting things naturally evolve is we've got, I think it's nearly 40 special interest groups. We've got quite a sporadic but engaged groups of people all over the country. And it's all been driven by the community. Next stage as we move into a community of thousands, so the first approach worked particularly well for a small group of people. Our next stage is taking a step back and thinking about all of the different gardens that are going on, really having a bird's eye view of the different sub-communities that we've got, and then thinking about how we can best channel the resources that we have to support them and to enable them to be relatively self-sufficient. Our expectation is that the community will never be 100% self-sufficient, but if we provide the right tools for people, they can get on with the job. They can be connecting with members themselves. They can be collaborating on projects on the online space themselves. And I think that that's my last slide. I think I'm handing back over. Sorry, Stacey, it's back to you.
Hi, thanks, Ash. Sorry, I was still on mute there. So that's it from us. And I know we've got some time for some questions. And we just finished off with the slide from John Berwick, who put the original report together, and he came to one of our events recently, last year actually, and was speaking to our key members, and so it's great to have his support in that. And you know, this does feel like quite uncharted territory for us, and perhaps to people on the outside, you know, it might start we're quite far on, and we've come a really long way through a challenging and exciting design process. And the question for the future is actually what kind of organisational form would a community have, and what could it have in the future? So that's one of our next tasks. But I'll close there. That's the end of our presentation. I know there's a few questions that are coming through on the chat there, and keen to hear any more from people.
Great. Thanks so much, Stacey and Ashlee. This has been great, and you're right, Stacey, that we have had a few questions filtering in through the chat. So at this time, I'll invite folks to continue to post their questions through the chat, but to get us started, let's use one that has already come in. So one from some of our other HQC colleagues, the question is, have you measured any social network analysis metrics over time to capture the growth or improvement of your network?
I can take this one, Ash, but jump in at any point. We haven't done this over time, and we have had some discussions about about this. And I think the challenge with this specific technique, as far as I understand it, is because it focuses on individual connections. So when you go through the process, you have to choose all of your individual connections, and we now have 2,000 people, and we'll have, you know, hopefully a growing community. So that's quite complex. So we haven't chosen to do that yet, and may not, but we need to think about other ways in which we can measure some of those connections.
I think, if I can just add something in, it's still very new. So we started to get new members we had founding cohort, but it's only been a year since we've had this other almost 2,000 people join. So it's difficult to work out exactly what it is that we are measuring before we go ahead and measure it.
That's true.
Thanks. Yes, that's definitely you illustrate the complexity of measuring that particular metric for sure. One of the kind of upfront questions that I'm very curious about, because as Gary mentioned, the Health Quality Council is currently kind of in investigative work of trying to translate how some of this work might be applicable to our local context. So one of my big questions is, I know that you've talked about this notion of kind of balancing between really letting the processes and the topics and the content be driven by the community members themselves. So I'm curious, in your kind of upfront setting up of your co-design, how articulate of an aim did you have, and how much did you allow kind of that initial cohort of folks to influence or shape that articulation of the aim of the group?
That is a great question. I think it's a really, and Ash can come in as well, we're both part of the co-design process, and actually my first day in the job was at one of the co-design events. It's a real challenge because it kind of comes back to the complexity that Ash described us working in. So working with partner organisations, other national organisations who may or may not have some clear views about what this could form into, versus a real kind of polarisation of ideas of what it could be within the founding cohort community, and then I guess the expertise and knowledge that I guess the Health Foundation brought through some of their other work. And I think, you know, we wanted to take a very kind of values-based perspective in that, you know, through the co-design, nothing was off the cards. And, you know, the downside of that is that you generate so much data, an overwhelming amount of data. And I think that was one of our big learning points, was that if you are starting from a blank sheet of paper with some wanting to collate all of that information, you walk away with an incredible amount of data and insight that actually takes a significant amount of time to work through. But then what you do is you go back and you test a draft operating model, and then you go back again and you test the next version, and every time it's iterating. But, you know, and Ash come in here, I think our kind of values piece around this was actually starting from scratch. And of course we all had some ideas, but we needed to really understand what the problem was we're trying to solve.
Yeah, absolutely. One of the things I found really interesting in the co-design was that there were a group of people or a large number of the founding cohort members who really embraced the opportunity to start something from scratch. And then there were a group of people, or a portion of people, who wanted to just know what it was that we were doing, and then they would get involved. And then there were another group of people who were convinced that we had this blueprint in our back pocket that we were just ready to whip out and say, here it is. And the truth is that we didn't, and it was one of the most spectacular things I've ever worked on. It was very difficult, though, as well. And one thing I think that I has really emphasised was that co-design didn't mean consensus, and we were never going to get everyone in the room agreeing on something. And I think that our original ambition, although we'd never really said it, so you can correct me, Stacey, but is that we had hoped that we would be able to make all 231 people happy, and the reality is that that's not possible. If you try and make everyone happy, you make no one happy, and there had to be a point where there were some decisions made.
Yeah, I agree, and I think that was difficult. And there will be people who are either in the community or not in the community right now who may not agree with the direction that it's taken, and it's holding that tension is very difficult. And a lot of that again comes down to the values and behaviour stuff about how you work with people, help them through the ambiguity and the difficulty when you're doing something like that. Does that answer your question, Chelsea?
Yeah, it certainly gives some further insight. So I'm curious, kind of building on this discussion, I'm curious as to what your process was in terms of identifying the members of that founding cohort. Was it by invitation? Was it by people who kind of self-identified as kind of early adopters? And kind of along that same vein, what did that initial invite look like? Was it, you know, we're thinking about how we can link our improvement network across the country or across countries. Do you want to come into a room and help us think through how that might happen?
Ash, do you want to start with that? Because some of that was before my time, so I think you'll have a bit of the history.
Yeah, absolutely. It was through a process of actually nomination. So we knew the landscape in terms of organisations really well, and so we approached, I think it was about 22, maybe a little bit more, organisations who nominated people, and what we were looking for was geographical and professional spread. So one of the areas which was we knew would be particularly challenging to reach was the patient leaders, and we're very specific about trying to include patient leaders in those nominations. And the other group of people which are quite difficult to get hold of are GPs, and just because GPs getting time off work to go and spend 6 days in total co-designing an initiative we knew would be challenging, and it would very easily get missed. But the answer is through a process of nominations. And we were looking for people, sorry, just to add, we were looking for people who had improvement skills as well. So it wasn't just anyone.
Perfect. So it sounds like you did have some kind of high-level articulation of what the aim of this group of people coming together would be doing. What was kind of if you were to kind of summarize the selling pitch of how you first introduced this concept to someone brand new that might be a good fit to this community, what was kind of your high-level synopsis or your original pitch to them?
For the founding cohort?
Yeah.
So there was in the Berwick report that Stacey talked about, there was a recommendation to create a system of national fellowships to put in place a system of continuous learning and improvement. And I think that was the ticket, really. That was what people wanted. And it was the opportunity to work with the Health Foundation, I think was quite, again, borrowing the brand of the Health Foundation, that was quite appealing. To take part in something that was really different. This hadn't been done on this scale before. And I think everyone had the belief that that's what we needed and that's what we wanted. And I'll be very honest, there were some people who turned up who actually weren't quite sure what they were doing there. They were requested to go as well. So they thought that we were there to do an initiative, to do a course perhaps, and that was definitely an interesting experience. In the interest of sharing different experiences, the first half-day session where people were they hadn't done the pre-reading and they hadn't quite worked out what was going on, but actually almost all of those people were fully on board by the end of those 2 days of really understanding, oh, this is what we're doing, we're designing something. And I think people took a lot of pride in the fact that they were designing something from scratch. And we still see it now. People introduce themselves as the founding cohort. They're not just Q members, but they were there at the very start. So I think that was it.
Yeah, and I think Chelsea as well. You know, the fact that it came out of a national recommendation holds weight when you're trying to gather support in the early stages. And you know, it was there's a whole list of recommendations that came out of that report. You know, following some really troubling levels of safety and care in one organisation, and that was. And that kind of lit the fire in some ways for this. And one of the things that within the report was about the investment in human development. So it was the requirement to have a considered and resourced capability building capacity for continuous improvement. And I think when you've got that in a national report, and it's part of a recommendation, I think that was the onus from where this all came from, which is partly why I included it in the start of the slides, because it's really important for us to remember where that came from originally, and that we've now been able to move into action.
Great, thanks for both of your responses. A question here from Francisco, joining us from our province over in Manitoba. His question is more around the operational side. So the question is, how many people work to support the Q network, and are they fully engaged in sustaining the network? So I'm guessing that's a question to kind of their work complement or their FTE complement towards that work.
Yes, so we have, in terms of numbers, we have about 18 to 20 people who are involved in Q. And the reason why I'm not being definitive is because it depends if you take it outside of the kind of central project team. So the approach that we've had is that we have a number of staff who are working full-time, and it does take full-time work. It takes so much more resource than we realised at the start. To get this off the ground, but we're also drawing on expertise from within the organisation who aren't allocated. Their time isn't necessarily allocated into working on Q. They're working on other projects, but it's really important that we're connecting it in with them. So we have a communications team. We have what you might call as an operations type team. Someone working in evaluation, and then actually. An important point in relation to the lab is that we made the decision to have a separate project team for the lab, and they sit in a separate office to our main office at the Health Foundation, because what they're doing is creating this space for their project, for their learning. So they have, so that's kind of a separate part of the team. So they're still very much part of Q, but they physically sit separate. Not all of the week, we make sure we have our meetings and our Zoom calls and that kind of thing. We connect the work up. But in order for the lab to be a success, we made the decision actually, when you're working on one thing for 9 to 12 months, you want to bring people into your space and work through it with them. And actually, we needed the office capacity outside. So that's the kind of number we're talking about. And of course, when you get down to the operational detail of finance and program management and your governance, that all takes expertise, time and effort as well.
Perfect. Well, thank you again, ladies, for taking the time to share your learnings with us. As I mentioned, we are particularly interested in your work and following it closely and learning as much as we can in order to kind of pursue similar ambitions in our local context. Gary, any?
Yeah, no, just again want to thank Stacey and Ashlee for the time that they put into sharing this with us, and in this ever-increasingly connected world and trying to connect with a variety of ideas, because local solutions are always going to be the better ones for what the needs are. You guys have really started some important work here, and we're just delighted to learn from you, and hope to stay in touch with you as we develop what we take from this in our Saskatchewan context. So thank you so much.
Pleasure. And I know there's a few questions that I left on the chat, so I'll have a look at those when we sign off the call, and then can share some answers.
Perfect. Thanks so much.
And
just a reminder to folks, we do welcome you to provide your feedback on today's session. You'll notice that a SurveyMonkey evaluation with 4 short questions will launch at the close of your WebEx, and we'd love to hear from you and get your ideas on how to continue to improve our offering. And just a reminder to also please sign up for our distribution list to ensure that you stay connected to our invites for our 2018 session. So we are wrapping up for the year. We'll be taking December off and resuming again in January 2018. So with that, I'd just like to wish you all a happy Thursday. So take care and stay warm.